All right. Welcome to episode number 7 of Esoteric Artifacts. I've got Jarryd Rivera, doctor, here in studio today. Glenn is still getting settled in at his new place in Maryland. He is going to be working for a quantum computing firm, like we mentioned last episode. So we're still working out the setup to be able to do our next episode with Glenn, but thankfully, Jarryd here was able to come talk to us today, and we're going to be talking about some of the problems in the healthcare industry, of which this is definitely a big discussion, but we're going to try and cover like some of the core aspects of what is the biggest disincentives and problems within healthcare from the perspective of a physician uh, that we have in the current environment that we operate in. Jarryd is a third year resident. Just as a disclaimer, he is here speaking his own opinions. He is not speaking on behalf of any employer or any organization. But yeah,
Yeah, thanks for having me.
so the first, like, where to start in this subject? it's
Oh man.
it's definitely a big one, but I think the Affordable Care Act is probably a decent starting point
Mm,
because that's the environment that most people at least operate in right now. If you are between the ages of, that you have just been born to 65, barring, low income people that are on Medicaid. And we can talk about Medicare and Medicaid as well, but
mm,
the Affordable Care Act, and we've been in this environment for, over a decade now.
mm.
Um, Actually, how long has it been? Has it been,
Oh, was it
10?
2016, I think is when 2010 is when they
Yeah,
voted on it.
yeah,
And
yeah,
yeah,
yeah.
2016
Yeah,
is
so
when it went.
12 years now,
Yeah.
we've been in this environment that was created by the rule, and it was the most drastic modifications to healthcare
Mm,
legislation that had been done in quite a long time. This country, everybody knows that the that our costs are astronomical
mm,
compared to any other countries, and there's a lot of reasons for that. And the Affordable Care Act really did not alleviate any of those
mm.
concerns.
Yeah, I mean, it was interesting that going into medicine, it's been about, well, like med school was about 8 years ago for me. Going into it, like we had heard about it and we thought like, oh, this is like the answer. This is, this is like everyone talked about it, like this is the next best thing. And um coming into it as the actual provider now, it's kind of different. It's not what we thought it would be. So there's pros and cons to everything. And I think that overall, it didn't meet up to the standards that it was expected to be.
Yeah, there was definitely a lot of promises that
Mm,
were made. And this is kind of the case with any legislation, but healthcare is such a sensitive subject because it's not just yourself that you're concerned about, it's your family members, your loved
mm,
ones, your spouse, your parents, your children. All of those people are affected by how healthcare is conducted. And people, of course, want the best that they can get. And
mm,
this country was widely known for many decades to have the we were at the cutting edge of every medical development. Pharmaceutical drugs to innovations within surgery. This country has always been at the forefront, and obviously that's not just been done by the private sector. That's been a lot of that has been done by public sector research and universities, and Europe and Canada and other countries that don't have the exorbitant costs that we have also have a lot of those benefits. But many of those benefits are passed down from us specifically,
mm.
especially in the area of pharmaceuticals. But I wanted to ask you, uh, has how much has your perspective shifted as you've become more and more immersed in within your industry, and you've seen firsthand so much from working in hospitals for
Mhm.
years as a and you, I know, interact with these systems a little bit more than perhaps some physicians do out of concern for your patients. I know we've had many conversations off camera about, you advocating for a certain thing for a
Mhm.
patient because knowing that they need it, but you've been denied by billing by insurance.
Yeah. So to start, like as a resident, we're still in training. So we are we're given a little bit more freedom into how much time we can spend with our patients, what we want to do. So this might not apply to all physicians, but um, just from the 3 years of training that we've done, um, you can see the shift that comes from year to year. So from first year, you get to start with an hour with a patient. Second year, you go down to 40 minutes, and in the second half of second year, you go down to 30 minutes, and then third year, you go down to 20 minutes with the patient, and that's actually like more time than most physicians spend with their patients. Uh, Once you're actually done with training, you're lucky to spend 15 minutes with a patient. And part of the reason for that is like there's so much need, like per you're getting paid for the volume that you're getting. So if you are working in your own private practice, you are getting paid based on the amount of patients you see in a day. So 15 minutes with a patient is going to pay you much better than even 20 or 30 minutes with a patient. And for you to sit there and like talk to someone and start from scratch and tell them, hey, like this is how we can improve your lifestyle in 15 minutes, it does not happen.
Yeah, it's a real challenge, and this is why nurses are perhaps more so on the forefront of a lot of these things than
Mm-hmm.
physicians, just because they are spending more face time with patients. But like you say, there's a financial incentive to not spend more time with patients, and it's come to such a point where it's not even financially viable for you to
Mm-hmm.
sustain a private practice if you were trying to do it the right way and you wanted to spend 30 minutes with every single patient. Because
Mm-hmm.
I mean, the rate of a consult with a physician, if you were to just schedule an appointment in a doctor's office in our region, which is not the most expensive in the United States, it definitely is higher in the West Coast, on the East Coast cities, but that rate kind of ranges from, like, if you were to pay for this cash out of pocket without insurance, it's anywhere from like 115 to like $150 for that
Mm-hmm.
consult. Most people, if you have insurance through your employer or something, you're probably paying like a $20 copay or nothing at all. So you don't even think about this. But I, as somebody who's lived without insurance for many years, right now, I just started a business 6 months ago. We do not have a group health plan
Mm-hmm.
under our small startup at this point yet. If I go see a physician, I will pay out of pocket, and that rate, if you think about those numbers, well, you have to have compliance software, you have to have billing software, you have
Mm-hmm.
to have accountants, you have to have legal resources, you have to have administrators, you
Mm-hmm.
have to have nurses, and then you have to pay yourself.
Mm-hmm.
Is it possible to do that if you're going to be seeing 2 to 4 patients an hour? You just
Yeah.
can't do it.
Yeah, and that was something that the ACA initiated, was that you are not paid on you're basically paid on your patients like compliance, and so
Really?
you can have, yeah, you can have that first wellness visit like paid for free, which is great. But again, 15-20 minutes, like how much time do you really have? And then from there, like you're basically paid on how well your patients are doing. So you're given 15 minutes to tell them, how to live healthily, and then you push the meds on them, and then from there it's like it's all numbers. It's all what's their blood pressure, what's their A1C, which is like a blood sugar measurement. And it's and those are the things that they tried to say, like, we're gonna pay you based on these metrics, and really that, like, none of those really matter in the bigger scheme of like someone's health, because you start off with a wellness visit, which is paid for, and then how often is someone going to pay an extra $100 to come to see their doctor, for their doctor to tell them, hey, like, stop eating this, stop doing this. Like, no one wants to be there, so those people don't continue to come. So, and then we're paid based on, well, the company is paid based on those numbers. It's all metrics. Like, that's what it's left up to.
That's interesting. I was not aware that there was like metrics testing
Mm-hmm.
for like evaluations in terms of insurance payouts. So you're telling me that, like, say a pre-diabetic patient with, fairly high A1C levels came in, um, if you were like, so in that sense, are you incentivized because you know that it's going to be an uphill battle to get them to change their lifestyle and change their diet? Are you then incentivized to, give them a drug that would reduce their A1C levels in the short term, even though that may not actually solve their bigger problems of poor diet and lack of exercise or
Yep,
something like that?
100%. So that's one of the big things that I have a problem with is uh, even with like bundled service or what's capitation is the other one.
Yeah.
Capitation. So a lot of these companies will say like we're gonna pay our physicians based on their metrics instead of like a time frame, which is that sounds great. They're using numbers. So like what he was saying was someone who's pre-diabetic, um, so someone who has like started to develop an insulin resistance, or someone who is at a level where they are their body's not processing the sugar the way that they should be. The easiest way to fix that is to throw insulin at them, right? Or a diabetic medication. So um, you could do that and make those numbers look great, but the worst thing about and something that I do not do or do not like to do is put someone on insulin, because as soon as you put them on insulin, all they're gonna do is gain weight. They're gonna gain more fat, and all you're gonna do is perpetuate the problem. So you're basically putting this bandage over like a excessive like bleeding artery, and to think that like that's gonna fix it. The number looks great, but guess what? They're gonna gain weight. They're gonna keep becoming more insulin resistant. They're go the problem is gonna not get better. But so that goes against like capacitation,
Capitation.
yeah, capitation, or all this like anything that you put a number on, you're actually not fixing the problem. You're fixing the number, and that's something that bothers me.
That's interesting because that's kind of one of those things where this obsession with metrics,
Mm-hmm.
which we know don't always paint the full picture. I mean, we talk a lot on this show about how the numbers that you see within the economy, for example, don't actually display what's really happening in the economy,
Mm-hmm.
because to, you have to take a more nuanced approach to be able to understand the bigger picture. And it's the same thing when it comes to a person's health, like you're saying, is there is a lot more going on behind the scenes than just this one number that we're able to measure. And
Mm-hmm.
especially, I mean, don't even get me started on mental health, where we're not able to quantify a lot of these
Mm-hmm.
numbers like neurotransmitter levels, and like we can't assess some of those things in real time,
Mm-hmm.
and they vary so greatly. So that's really interesting. So I had never heard that term, but apparently capitation is it's a payment arrangement for healthcare service providers that pays a set amount for each enrolled person assigned to them per period of time, um, whether or not the person is
Mm-hmm.
seeking care.
And that's kind of what Affordable Care Act did. It was trying to find a balance between fee for service and capitation.
Hmm.
It was trying to find some kind of balance where they bundled like fee for service and said like we're gonna pay you for seeing this person, but it doesn't always match up to like those numbers. And like one person being sick, you can't just like put that in a bundle, which that was the downfall. Like they tried, well intentioned, but you know.
Yeah. So it's interesting hearing some of this stuff from me, because I am hearing it from like coming from my insurance background. I was a Medicare agent for a little bit over a year, and I got to see some of the financial side of interfacing with government and how these payments are processed by Medicare, which is a pretty solid insurer
Mm-hmm.
in itself. This is why there's so much political will to expand the Medicare program to cover everybody. But the reality was, even when I was in Medicare, was most patients that wanted actually high quality care did not just accept base Medicare and then one of these free HMO plans that was provided by one of the insurance giants like Humana or like Anthem, the best care that you could receive was with a supplemental plan. Now, there's plenty of problems with these supplemental plans as
Mm-hmm.
well. They were not a perfect solution by any means, but they granted patients freedom of choice, essentially, to
Mm-hmm.
seek care in the way that they thought best. It allowed you more flexibility of options of not being constrained within a network and being able to go to the hospital you wanted, being able to attain the operations that your physician recommended without as many limitations. And one thing that I think people are asking themselves, especially people that have been on these Affordable Care Act plans that were kicked off their whatever plan they were on prior, and this is not some. This is part of the issue is that health insurance is indexed heavily to employment in this country.
Mm-hmm.
I don't think there's any other country in the world that has it indexed to employment so heavily, but there's heavy financial incentives for good employers anyway to provide that benefit to their employees. So most people, even most people that are listening to this right now, probably have a group health plan that a portion of that premium is probably deducted from your paycheck,
Mm-hmm.
and but ultimately any portion of that premium that your employer is paying, that's tax deductible for them.
Mm-hmm.
So they're kind of incentivized to offer that as a benefit, because rather than offering you more compensation, because any wages they're paying you, that's not tax deductible, but
Mm-hmm.
premiums paid is tax
Mm-hmm.
deductible. And then on the more extreme cases where you have like really good employers, like a company like Google, for example, they're paying the full cost of premium. Some manufacturing companies will do that as well. Actually, I worked for a factory that paid the full cost of premium, which would have costed me probably $120 out of pocket per week,
Mm-hmm.
which is ridiculous because I think I was 27 at the time. Like
Yeah.
the odds of me, needing insurance for anything
Yeah.
other than barring catastrophic incidents is extremely low
Mm-hmm.
in that age range. And yeah,
Which is funny because that was part of the thing that they were trying to, the Affordable Care Act was trying to show is like, oh, we're going to save the patients their money. But like, yeah, premiums.
yeah, and especially if you're like upper middle class, I mean, you're getting shafted the
Mm-hmm.
hardest by this. I walked into households that were not quite on Medicare yet. That was the thing. As a Medicare agent, I spoke to a lot of people that were on these Affordable Care Act plans,
Mm-hmm.
because people who were 64 and getting ready to enroll in Medicare was a lot of our prime clients, and those people would describe to me, there was a guy who was making like around $150,000 a year on a single income.
Mm-hmm.
In our area, that's very comfortable living.
Mm-hmm.
That's not making 150K in New York City.
Mm-hmm.
You can live quite comfortably on 150,000 before taxes in this area. However, he was paying $1,800 a month in premiums for him, his wife, and two children, and I was like, that's insane.
Mm-hmm.
They had children late, so they still had two dependent children at that time when he was 64, and I could not imagine the idea of paying $1,800 a month. But the alternative to that is facing real risk of losing all your assets. Filing medical bankruptcy in the event that something major
Yeah.
bad does happen to you.
Mm-hmm. Which still happens.
Yeah, medical bankruptcy, I think maybe still one of the most common,
It-
if not the most common form of bankruptcy in this country.
Yeah. Last time I checked, it was, yeah. Um, yeah. And like, and going with that, it was, I think right now it's about 30, the cutoff for Medicaid and of course they don't, they don't put that on their website, but you have to apply and see if you qualify. But I think it's about $20,000 to $30,000 a year is what qualifies you for Medicaid. So
Medicaid.
most of our patients
You're talking in terms of income.
yeah.
So that is actually indexed to federal poverty level.
Yeah, the federal poverty.
So it varies. In California, I believe it's like between 350 and 400,000% federal poverty level. Federal poverty level, I think, is
I thought it was 100 to 400.
so.
100
I'm gonna check my
400,000.
numbers real quick on this. A federal poverty level, I can't remember if it's like around 12,000 or if it's around 16,000 these days.
Which multiplied out to
Yeah, there's a multiplier that's I haven't checked it in recent years, so I will just look it up. The under the current guidelines for a single person household,
right.
we're talking. Obviously, the equation changes if you have a dependent spouse, if you have children. But for an individual, federal poverty guideline is $13,590 in the year 2022.
So
And
you multiply that out by
yeah, so that gets Alaska is the only state that has
mhm,
completely different federal poverty guidelines because it's strategically important territory to us, and the cost of getting goods to Alaska is very, very expensive. They
mhm.
actually get paid a government stipend just for living in Alaska, which is kind of funny. But yeah, so there's a multiplier for some states. That multiplier might be like 150% if it's like a lower cost of living state. If it's a
Mhm.
higher cost of living state like California or New York, it's a much higher multiplier on that
Okay.
federal poverty level. And that was one of the things that the Affordable Care Act actually did was it um, it allowed the states to expand certain benefits. Not all states did this, mind
Mhm.
you.
Yeah, you
Many
could
states that were
waiver out
governed
of.
and that had Republican majorities in the House and Senate, and
Mhm.
Republican governors refused outright to
Mhm.
expand Medicaid because they didn't want to create an incentive for more poverty, essentially
Mhm.
in these states.
So how did those states do? Because when like while I was looking it up, like I they were using Texas as an example,
Yeah.
and they were the number they were using was like the number of uninsured or the number of healthcare costs, like whatever.
hmm
So how like have you seen anything different?
Um, I'm not sure exactly what you mean, like in
Like
terms of
how did
assessing.
it like like how did it benefit the insured patient?
Oh, well, so I don't know how they assess
Yeah.
whether like they will just look at those numbers in a simplistic form,
Mhm.
like we're talking about. This
Yeah,
is
yeah.
the problem. Bureaucracies love these types of numbers
Mhm.
because they can say pre ACA there was 10 million people
Yeah.
that were uninsured in this state.
Yeah.
Post ACA there was only 6 million people that were uninsured in the state. So from that standpoint alone, it looks like a success.
Yeah.
But that doesn't paint the entire picture,
Yeah.
right?
Yeah, and again, I can only speak for Ohio. Like, I've never practiced anywhere else. I don't plan on. Well, maybe I'll
Yeah.
practice somewhere else. But again, like Ohio specifically, um, most of our patients as a resident in training, like you're only seeing you're mostly seeing Medicaid, Medicare,
Yep.
and and actually a lot of uninsured too. And there's a lot of people that are making, $30,000 a month or 35, and they don't qualify for Medicaid because they're, they're taking care of their grandkids and whatever. Like there's so much crazy shit that happens in Southern Ohio that like you can't account for in someone's salary, and it's not fair. Like I don't I think the people that really get screwed over are between that low class and that middle class, and like just to say like affordable care should be for everyone, like it really doesn't apply to everyone.
Well, man, there's some really disheartening things that people had to do in order to qualify for Medicaid. Sorry. I This is not commonly employed, and obviously this is people in higher income situations. But sometimes these costs can be astronomical.
Mm,
If you talk about somebody, let's say somebody that is in their like maybe 65, 70 years of age, somewhere in that range,
mm,
and they have, let's say they have 2 million in assets. Okay.
mm,
Let's say a $500,000 house and 1.5 million sitting in there in between savings and retirement accounts. That's not, you're not rich if you, even if you're sitting on 2 million in assets. You by no means are you rich. If you even at that point if you retire at 65, you'll be lucky if you have anything more than your house left to give pass down to your children. And people that are in those situations, and especially in that net worth range between 2 and 5 million, is where we saw this a lot. Because we had elder care. We were partnered with elder care attorneys that would specialize in these types of things, and there is what's called a Medicaid trust. What you can
mm.
do is you can lock your assets up in a trust, and then tell Medicaid that you did this. uh, you're basically telling them, hey, I locked up my assets in my trust, so my on paper my assets are non-existent. I have nothing, and they'll tell you, okay, that's fine. You will not be eligible for Medicaid for a period of I think it's 3 years. So for 3 years, under no circumstances, even though you technically meet the parameters for qualifying for Medicaid, you are not permitted to enroll. However, after that 3 year period, so somebody with like early onset dementia or
Yeah.
Alzheimer's, who knows that they're going to need very expensive years and years of long term care. Alzheimer's is one of the worst ones because
Mm.
especially women, who are just tend to live longer than men and are physically healthier,
Mm.
after their mind has gone in a situation like Alzheimer's, we would see families doing this, locking their assets up in a trust, telling Medicaid because they know that they can't afford the nursing home costs 180 to $240,000 a year. They know that they can't afford that, and they don't have enough family to like step in and to provide full time home care for their mother or their grandmother. It's a really tough circumstance, and I've also seen people get divorced, have to get
Mm.
divorced after 40 years of marriage
Mm.
in order for one spouse to qualify for Medicaid, and that is just the saddest thing. When like even if it's not a real divorce and it's just something that they're doing on paper to
For
be able to
Medicaid or
navigate this.
Medicare?
What's that?
Medicare or
To
Medicaid?
get onto Medicaid. Yeah, yeah. Um, yeah. Just seeing those situations and the fact that because rules and laws have to be written to fit, like you can try to account for every circumstance, but you're never going to be able to, right?
That's true. Yeah. I mean, it's also like really messed up that especially older people are led into this like this lie that okay, like you have this much like savings, you have this much social security and retirement
Yeah.
that like when things go wrong, this will work out. And then to see their face like when they're like, "Oh, no, you actually don't have the house. Like you don't have that much that mu- so in a trust like they that's protected."
So your house is the only asset that is actually protected, under Medicaid, but it's not protected permanently. It's protected while you're still alive. So what will happen is if you, let's say you needed Medicaid,
Mm.
like Medicare plus your supplemental plan or
Mm.
HMO could not cover the full extent of care that you required in old age,
Yeah, yeah.
then you'd be dual enrolled. You'd be enrolled in Medicare and Medicaid, and you would have to spend down all your assets. So any savings, I think you were allowed to have 3,000 in liquid assets, which is nothing, right? That's absolutely nothing. If you're on Medicaid, I think I believe it's 3,000, unless those numbers have changed since I did this, 5 or 6 years
Mm.
ago. But even if it has changed, I don't imagine it could have changed by much.
Yeah.
So you have to spend down all your 401k, your IRA, whatever, all of that has to be
Mm.
liquidated, and essentially spent because what else are you going to do with it? I mean, you can transfer it to your heirs, in advance of your passing, but there's tax implications to that as well. And what the one asset that would be protected that you're allowed to own that would put you in excess of the typical qualifications for Medicaid is your house. But what will happen afterwards, if the cost of your care exceeded the value of your home, the government will then own your home after your passing. That asset technically does not belong to you. You cannot pass your home down to your children. After, and your spouse is also protected though. So like if let's say you as a man were the primary breadwinner
Mm.
in your home, and you had to get on Medicare, Medicaid, and your assets were spent down. You, let's say your spouse survives you for several years.
Mm.
The government would not seize your house while your spouse is still alive. But after your spouse also passes, they would own that home. And actually, the federal government owns an increasingly large amount of homes. And yeah,
So that's what I was asking you is like I've actually seen like one of the months of my training is palliative care, which is
Mhm.
people basically like they're on their they're on their last stretch, they're on their dying bed,
yeah,
and um I've had a couple patients or with the patient's like family where the wife is like, "Oh, I have the house and so we can pay for, we have savings, like we can pay for everything." And then like they said like we can't go into this decision because we're going to lose the house. And that makes no sense to me. Like I didn't know that like they can go after your house.
so yeah, they mean they're in the long run they will lose the house, but while they're still alive, no, they won't lose the house. But yeah, they can. They'll go after any asset that they can to recover it. If the government has to spend, like a government run assisted living facility, for example,
Mm-hmm.
probably charges somewhere around in the range of like $120,000 a year, right? Between 120 and
Mm-hmm.
$150,000 a year. Let's say you own a $450,000 home. That's a pretty decent home in most parts of the country. Less so today, but
Yeah, yeah.
except a couple of years ago, that was probably a decent home.
Mm-hmm.
Probably had a little bit of land with it. Um, that, but you required 3 years of assisted living care. The government would then say, well, that the home needs to be sold. I believe they put it into auction, but I'm not exactly sure how that. I think
Probably, yeah.
I think they do it as a bulk auction of sorts.
Yeah.
The government will take a collection of properties that they have from this because we have an aging population. I mean, this is something we
Yeah.
talk about
Oh yeah.
on this show. This is happening to a lot of people every single day. It's,
Mm-hmm.
may not happen to many people you personally know, but around your state, around
Mm-hmm.
our country, this is happening all over the place. And I have not really been able to find a lot of information on what
Mm-hmm.
is happening to these homes, but I know the government is not just sitting on them. They're,
Mm-hmm.
they're recouping their costs, but um,
And that's something that,
yeah,
like, I'll say, like, as a provider, like, we don't deal with that because we have social workers who, like, thankfully we have social workers who try their best to, like, make everything work out for the family, but, like, we don't make those decisions. Like, we try our best to, like, get them to a place that, like, where do you want your loved one, and beyond that, like, we leave it up to the social worker. Like, we say, like, hey, like, this is what they want, so either get them home, get them to a nursing home, and you take care of the rest. And we don't really get to deal. I don't want to say, like, get to deal with it because it's a lot, but
well, you wouldn't have the time to, assist every single patient that you have with
mm,
navigating this complex process. It is, to a degree, people have to handle this themselves. It's between them and their families, and there's a severe lack of education on this
yeah,
reality.
that's
And
the
this,
problem. Is, like,
yeah,
people, like, don't realize, like what happens when my spouse is on their, like, last month of living. Like, how do I take care of them? Like, they just think that they're taken care of, and
yeah.
a lot of people, like, don't like have that. I don't have any education on what happens here from here.
Yeah, I mean, we're dealing with this within our own family right
Mm-hmm.
now. This is a common struggle that
Mm-hmm.
people undergo, and most people aren't prepared to deal with this until it actually happens to them,
Mm-hmm.
and then it's by that point it's too late. And that's part of the problem, is that, like you say, you might get 15 minutes with your patients, once you're out of residency and you're going to be practicing. That is not enough time to
Mm-hmm.
educate them on the nuances of this. Even if everyone within your profession was educated on this, it would not be enough time. And the other issue is that when people like me would go in and speak to these people, I would run a 1.5 to 2 hour appointment with these people in their home. We're having very intimate conversations about their health, about their financial situation. I was also a life insurance agent, so other things would also be discussed, aside from the healthcare thing. But at the end of the day, I am there trying to sell them something.
Mm-hmm.
My company was one of the few insurers that was still offering long term care plans. Long term care plans was a type of insurance that, because of the extremely high claims rate on it, a ton of insurers just stopped carrying it altogether.
Mm-hmm.
It is a very difficult insurance to carry, and even when you do carry, it's very expensive. And most people at that time just think to themselves, "We'll deal with this if it happens to
Mm-hmm.
us." They're like, they can't stomach the idea of paying $18,000, $20,000 a year in premium,
Mm-hmm.
even if they can afford it pretty comfortably. I walked into many households where they could comfortably have afforded the premiums on this. They could not afford to self-insure when it comes to actually needing that long-term care, though.
Mm-hmm.
And actually, in the Medicare booklet that you get when you turn 64, I think when you're 64 and a half, the government sends you like a booklet on Medicare with
Mm-hmm.
a detailed information booklet. It's 80 something pages, I believe, and there used to be an entire section devoted to this rising long term care problem. They have now reduced that down to one paragraph. That one paragraph of information is what the government is providing you on this.
That's crazy.
Yeah. So another thing that we've talked about that you told me, it was just some of the situations when you do get to interface with, and we talked about how the rate of bureaucrats and administrators
Mm,
and various personnel within hospitals. Hospitals have become a very complex beast. It's not like it was 80 years
mm,
ago, where it's just a doctor and their patient. It was just person to person. It's this massive, complex industry that so you don't interface with a lot of these situations like we're talking about, and you don't fully know what the
mm.
issue is, but you have had some situations where you advocated for something and were told no.
Yeah. Well, I mean, one of the things about paying like as a bundle is you have to, well, in a hospital like setting, when someone gets admitted, you have to give them a diagnosis. So you have to say like they are admitted for pneumonia, and then you have to say like also on top of pneumonia they have sepsis, which is like a severe infection. And if you put those diagnosis codes on that person, you're gonna get paid more. The hospital will get paid more, not the doctor. We get paid a salary. So when administrators get involved, it becomes a lot more um again like numbers. So if someone meets like if someone's heart rate is elevated and someone has a fever and they get admitted for pneumonia, you have like if you don't say that they have sepsis, you get scolded. Like we get scolded because the hospital gets paid more. So again, like admitting someone for a simple infection is fine. We can treat that. But if you say it's a severe infection, the hospital gets paid more. And if you don't say that, then we like the provider gets scolded. So again, it comes down to the numbers. It's like if you want to put numbers on medicine, you're at a really high risk because all of a sudden you're saying that just because someone has an elevated heart rate and a fever and a white blood count, which can be caused from all different types of things. Like if someone's in pain, their heart rate's going to be elevated. They're going to have a white count. You can say all those things. If you as a provider don't put that diagnosis code on them, you'll get scolded. So the hospital administrators who really profit from this like want you to say this is a more severe infection. And it's actually gotten to a point where like a lot of the older doctors who know what they're doing are in contention with the administrators because the administrators are hiring these billing people to look at these numbers and say like, why did you not like chart that? Why did you not document that this person was in a severe infection? This is one example. And they will email you and they'll scold you and they'll say like, hey, like if you're not doing this, like we're gonna come down on you. Again, down to the numbers, and like the doctor knows whether this is severe or not. Like, why are you not putting them in the ICU? Why are you not doing this? Why are you not putting them on telemetry, which is an extra cost? Like, and that takes away the control from the provider because once you put things on in numbers, it's a metric. It looks, in theory it works, but it takes away the control from a doctor going in there and saying, "I know this person is severely infected," versus they're a little bit infected. They can go home and take antibiotics. Like,
Yeah.
and that's scary to me because again, you're just putting numbers on it.
I imagine this has probably only gotten tighter in this like post-pandemic era that
Mm-hmm.
we're in because of how much losses hospitals underwent from not being able to conduct all these elective surgeries and a ton of other procedures that would typically bring in a bunch of revenue for them.
Mm-hmm.
So I bet there's probably, have you noticed an increase in pressure? I know you haven't, been in the profession for that long, but you've been in the profession through the height of the pandemic
Mm-hmm.
and into now. What are your thoughts on that?
Well, oh, what do you mean by procedures? Because from what I understood from the Affordable Care Act, they took away like the paying for procedures. So
What do you mean?
Um, so they took away like fee for service, which would be like you get charged for a procedure in the hospital.
Yeah, but I'm
With a
talking
specialist,
like I had read a number of accounts that say that hospitals lost a ton of revenue to loss of elective surgeries. They weren't scheduling these elective
hmm
surgeries
oh
because of the
yeah,
pandemic,
yeah.
right? So is that, do you think that that loss of revenue that was experienced in 2020 and in 2021 is
hmm
increasing this pressure to chart and code certain ways?
I don't think it changed it much.
Yeah.
I mean I think it was interesting that during the height of the pandemic, the specialists were actually, well, the first people that weren't at the hospital were the administrators, and then second were the specialists. So I'm not talking shit on any specialist, but like the cardiologists, the surgeries were all canceled because they were all trying to avoid, they just don't want to deal with it, which
Yeah.
is, that's fair. Like they've gone to extra schooling, they've done extra training to get to that point. Um, since then, I don't think I don't think they've overcompensated.
Yeah.
I think they're still the same that they've been, like where again, it's metrics. Like if a cardiologist takes you to the cath lab because they think you have a heart attack, if you die on the table or if you die within 30 days, that looks bad on them. So they will avoid at any cost. They will try to avoid taking you to a procedure to clear up your coronary arteries. But again, I didn't train before that, so I don't know. Like if
Wait, why
that's
would they avoid taking you to that procedure?
because if something happens, well, obviously, if something happens in the OR while they're doing that, then that's a dig on them.
Yeah.
If something happens within, I think it's like 30 days,
Mm-hmm.
or it's like 2 weeks or 4 weeks after they've taken you to the cath lab, even if it's not related to what they did, it's a ding on them.
Mm.
So our cardio our cardiologists will avoid taking people to the cath lab if they're high risk. If someone's old or has other things, they will make excuses for saying, "Oh, you know, that person has lab work that shows that they're probably having a heart attack, but it's probably because of something else."
So you're saying this is affecting the decision making process, like incentive to this incentive system, I should say,
Yeah,
is
yeah,
affecting the decision making process. Do
yeah.
you think that we're reaching a point where the financial incentives within our healthcare system are causing more breaches in medical ethics?
I think it's I think it's taking away from providers making a decision based on what they know.
Yeah,
I think they're smart doctors and they're making bad decisions because of that. And again, I can't speak for before the pandemic
sure.
because I've only been in this since then. But yes,
Hmm.
I think it's taking away decision making from the physician.
Interesting. All right, we're going to take a quick break, but we'll be back in just a minute. So hang tight. All right, we are back, continuing our discussion on problems in the healthcare industry. We've spent a good amount of time talking about Medicare, Medicaid, the Affordable Care Act, and I think one of the important things that the Affordable Care Act did address, that was by far the most popular provision of it. If you ask people today, do you think this is important? That's the protections on coverage for people with pre-existing conditions. Because prior to the Affordable Care Act,
Mm-hmm.
insurers had a lifetime maximum on coverage, and some people with, these are outlier cases in the most for the most part, but some people would hit that lifetime limit while they're in their 40s, not when they're 70 years old.
Mm-hmm.
And then they would just be uninsurable after that point, especially people with certain chronic diseases, people with rare genetic disorders that would, gave them a higher propensity to develop certain illness. I would imagine AIDS is another one
Mm-hmm.
that would probably cause somebody to hit their lifetime cap. And all of these things had been building up over the course of several decades, where people just saw this perceived injustice in the fact that some people just could not be covered anymore. And like we were just talking about while we were taking a break here, I had a client once, or actually he was not my client, but he was somebody I sat down with as a prospective client. A man with a rare genetic disorder that gave him a high propensity to developing various types of cancers. And this man was in his 40s, and had a wife and two children that were that depended on his income, and he was a former insurance agent himself, so he knew how to navigate these situations. But he had had cancer 7 or 8 times, I believe, by the time I'd met him. This was 5, 6 years ago, and that is the type of outlier case where that just in order to receive the necessary care he needed to stay alive, he would have probably exceeded those lifetime coverage limits prior to the Affordable Care Act. And what is he to do? Is he to just say, well, I guess I can't receive treatment for the cancers that I know I'm going to get way more frequently? I mean, cancer is something that affects, all humans, but it virtually, I mean, there's genetic reasons why we will essentially, even if we were able to prolong our lives past a certain point, we cannot stop cancer. And that is why cancer research is such a hot issue. So cancer charities generate some of the most revenue of anything, and yeah. So circumstances like that, I just find it interesting that that one provision being included was one of the main reasons why the public really wanted the Affordable Care Act.
Mm-hmm. Yeah, I mean, there's a lot of chronic diseases that people live with that they're insured, that they go into being insured with, but like there's also things that you can do to modify those. There's a lot of modifiable risk factors, is what we call it.
Absolutely.
And it makes it difficult to distinguish what are you born with and what are you what are you destined to have and born with, or what can you actually fix? And that's tough to you can't put that into numbers.
Yeah, so in our region, I mean, the two most common ones, you were having worked in rural hospital systems, probably saw a lot of this, but diabetes and COPD.
COPD, yep.
Yeah, two extremely common ones that, and I always get these mixed up. Is it type 1 or type 2 diabetes that is that's a product of lifestyle?
Type 2.
Type 2. Okay, yeah, I always get those mixed up. So type 2 diabetics and people with COPD, that is largely caused by lifestyle, right? There's things that you can either stop or things that you can ameliorate the effects of by making simple lifestyle changes.
Yeah. Yeah, I mean, and that's the problem with those things that are you go in when you're insured with that. It's when you have COPD, you can't fix it. It's actually irreversible.
Yeah. But COPD is one where you would have had to have made changes to your lifestyle like 15 or 10 years prior to prevent yourself from getting right. Stop smoking.
Yeah. And there are genetic causes for emphysema that is similar to COPD that you can be born with, that someone who's never smoked a cigarette in their life can have COPD. But there's also, we know that if you continue smoking, that's the single biggest factor that's going to stop the progression of it. It's not going to reverse it.
Yeah.
It's going to stop the progression of it.
Well, and there's absolutely people that still continue smoking after receiving their diagnosis for COPD, right?
Yeah, we see people that are smoking while they're on oxygen, they continue smoking even though there's a risk of explosion. They can smoke a cigarette and in concentrated oxygen, they're going to blow up. But it's not going to reverse their COPD.
Yeah.
Which I think that's the biggest problem is if we told them that we can reverse your disease, your chronic disease, if you stop smoking, maybe people would be more open to it. But the fact that we say oh, it's not going to get worse, it's a fallacy of loss. People have already gone that far that
Yeah.
they don't want to.
Yeah, yeah. I mean, that kind of is like a gambler's fallacy, like you
Mm-hmm.
say. It's like you feel you've already lost everything that you could,
Mm-hmm.
so why not? Um, and yeah, you guys really are limited in your treatment options. Not necessarily for these types of conditions in particular, but just as a product of uh, Western medicine's heavy reliance on pharmaceuticals
Mm-hmm.
as a solution rather than because, like we've been talking about, the limitations of time, like
Mm-hmm.
you not having enough time to teach a patient how to live a healthy lifestyle. You would have to spend hours with a person in regular consultation, getting frequent updates from them
Mm-hmm.
and working with them, kind of the way a personal trainer does.
Mm-hmm.
You would have to work with patients on improving their diet steadily over
Yeah.
time and on teaching them how to exercise and ensuring that they're, following up with those plans that you're creating for them.
Which
So
is not like universal. You can't just say like this is the best diet for you. You have to like see how
yeah,
that person reacts. So,
absolutely.
but yeah, it takes multiple like encounters, and you have to see them back like every couple weeks and see like is this working for you? Like let's see how your blood work looks. Let's see how your weight is doing.
Well, so in that approach that you're talking about right now sounds a little bit like a functional medicine sort of
Yeah.
approach, right?
Yeah.
Can you explain a little bit like what functional medicine is?
I've struggled a lot with that. I I think functional medicine will focus a lot more on like hormones and how to fix things without medication, which I agree with. But there's also room for medication. There is room for um, weighing out the risks and benefits of using a medication to help prevent you from having a heart attack, prevent you from having kidney disease, whatever it is. Like there is room for that, and I think functional medicine is a little bit on one extreme of the spectrum.
Gotcha. So on the one hand, there is immediately prescribe whatever, the guidelines
Hmm.
suggest, and then on functional medicine is on the other extreme of
Yeah.
let's do everything we can to avoid
Hmm.
prescribing something.
And I think their downfall is where they say like we can fix this without medication. Like yes, to a certain extent there is room to work on hormones and lifestyle, but at some point you have to say like this is time for us to intervene with medication.
Well, and yeah, I mean, people go to some pretty extreme lengths, especially people with autoimmune disorders.
Mm-hmm.
I've heard, yeah, Michaela Peterson, Jordan Peterson's daughter, I know is like one of those people. She's on like some ridiculous carnivore diet, and
Yeah.
she says that it is the only thing that keeps away her autoimmune disorder symptoms.
Mm.
And like I think she only eats one type of meat. I think it's like elk or something. I don't think it's elk, but it's like it's not like one of the common proteins that we all eat.
Yeah.
I think it might be lamb actually. But
Oh,
yeah,
that's
imagine eating
good.
just lamb, like nothing else, and like that is definitely there are people on the fringes of that, and some people say it works for them,
Hmm.
but how are functional medical doctors, doctors that practice this extreme, how are they perceived in your industry?
Honestly, they get a really bad rep.
Yeah,
They and I think part of it is because there's like such a controversy between the two. It's almost like functional medicine versus traditional Western medicine, and I don't think it should be like that. I think there is a balance, and there is like a there's room for treating chronic disease with lifestyle and taking care of yourself, and then there's medicine, and at some point like you might need medicine, but I don't think that I think that they just like clash so much because of that. Like,
what are your thoughts on like what I would describe as the overprescription of psychoactive drugs for mental health reasons in
mm,
particular? This is something that we've seen become, expand greatly over the last 2 decades,
mm,
especially. And a lot of that is awareness and destigmatization
yeah,
of mental health issues. But on the one hand, I was told when I was young that I had ADHD.
mm-hmm,
Um, I probably do. I mean, I meet all the DSMs
Yeah, DSM-5.
criteria for
Yeah.
that. However, rather than teaching me methods that I could employ, my parents were opposed to medication for it, and
Mm-hmm.
I'm now grateful for that
Mm-hmm.
because I had to, it was a hard road to get here, but I had to teach myself different methods and employ different techniques to maintain focus.
Mm-hmm.
And upon doing that, I found that I was able to live successfully without medication.
Mm-hmm.
However, the immediate goal of the medical industry was to prescribe Adderall, Ritalin, Strattera,
Yeah.
try all of these different options that caused other complications for
Oh
me.
yeah.
And when I did try them, and that would like I think now retrospectively that those would not have helped me because I would probably still be reliant on those
Yeah.
drugs to get through my day.
Yeah. I always describe it as like it's a transition to get you to where you need to be.
Hmm.
I think a lot of people use it as a permanent fix,
Hmm.
and it's not that. It shouldn't be that. Like medication should be, well, for especially for like depression, anxiety, ADHD. Like it should be something that helps you get to where you need to be. And I don't think people look at it that way.
But don't you think that it also simultaneously inhibits you from it? Like it takes away any incentive you have from, like I said, like learning those
Hmm.
techniques or
It
employing
it
different
depends on where
methods.
you're at in your life. Like if you're 7 years old and someone puts you on, you know, Adderall and Zoloft, and like of course, like you're never gonna know anything different. But
Hmm.
and that goes back to the parents. Like
Yeah.
what incentive do they have to help their child get better? Which goes back to the culture. Like that's tough.
Yeah, and parents have, less time with their kids
Hmm.
these days. You have both parents in a household typically working.
Hmm.
Um, the
We have 5 year olds that are on antidepressants, and it's not.
Really,
Yeah, it's sad.
man, that is concerning.
It is. And at the same time, it's like as like when you're the one that's like looking at this child and the parents, and you know that the parents are not going to take care of what they need to. What do you do? I mean,
Yeah, I mean, I imagine this is very similar to the what social workers experience.
mm-hmm,
When they go into a household and they realize the parents have no will
mm-hmm,
to make this situation better. So this child is just going to be reliant on these resources from the state, essentially indefinitely until they become an adult,
yeah,
and in some cases, even after. But yeah, it kind of breaks the incentive system, and a lot of these things, whether it's health, whether it's mental wellness, whether it's whatever it is, requires a lot of work and effort, and not just on the individual, but also on people with immediate support structures with
mm-hmm,
the family, schools, churches, and any member of their immediate community. Um, a lot of those institutions have been degraded or have been bureaucratized, right?
mm-hmm,
And I really think that just inhibits people from being able to deal with their circumstances.
mm-hmm. Yeah, yeah. It's kind of funny, like because like we don't focus on. I mean, to talk crap about us, like we don't focus on like, hey, what's really going on at home. It's like, oh, your kid's acting out, like what can I do to calm him down? And it really is like we focus on how do we patch up this problem instead of what's really going on. And we really can't, like, because if you say something negative about the um like the traditional family, or why are you not with their parent, like you get ostracized. Like you can't, we don't have the room to talk about that.
Well, and when you're talking about children, the parents are bringing them into you as a
Hmm.
provider. So if you say something critical to this parent, like about something that needs to change within how they conduct their household, they're just not going to come back to you.
Yeah.
And so you lose any chance you have at
Yeah.
helping that kid's situation.
Hmm. It's sad. And that's probably one of the, like the worst things is like the biggest reasons I would never go into like primary care is because you're taking care of a patient, but you can't fix the lifestyle, the family around it.
So how does primary care differ from your specialty, family medicine?
Well, traditionally, like family medicine would go into primary care.
Really?
Yeah, and I actually like I don't think I can do it because of that's one reason is because you can't fix like the family around it, and this you they call it family medicine, but you're taking care of one person and you can't fix like their situation they're in. And number two is because the insurance companies really like dictate what you do and how you take care of that patient.
Gotcha. Yeah, because you were sharing a story with me quite recently about a patient that you had that was unable to lose weight
Mm-hmm.
and was pre-diabetic, I believe, as well.
Mm-hmm. Oh,
And
not no, yeah,
they
not
were
even pre-diabetic.
oh, so they were not pre-diabetic, and that's why you were not able to
Yeah.
get the drug prescribed for them that you recommended
Mm-hmm.
because the insurance company didn't want to pay for it.
Mm-hmm. Yeah, there was someone that I was working with that was she had a binge eating disorder,
Hmm.
and she also had like anxiety, depression, and again like born in like Southern Ohio, like you know was was raised in a family that um didn't have like healthy lifestyle choices.
Hmm.
And so she came to me like after like multiple different like doctors, and she's like, yeah, like I've never gotten along with these doctors. And it's like it's understandable. Like
Hmm.
she was non-compliant. She didn't believe in anything that the doctors told her. And she she basically was out of options. And so I sat there and gave my 30 minutes of whatever I could do. And she came back the next time and she's like, yeah, I didn't lose weight because I can't. Like, I don't have time. I don't have the energy. I checked her for like all the, like the thyroid, vitamin D, like everything I could check for that would explain why she doesn't have the motivation. And then she's like, yeah, yeah, I tried the diet, like the lifestyle and diet that you told me. I just can't. I don't have the energy to cook my own food, and I don't have the energy to work out. And then that makes me like continue to gain weight. And then because I don't have the energy, I can't. It's a cycle.
Hmm.
And so I said, okay, like, well, let's try medication. Um, there's certain things that you can't do when someone has a mood disorder like depression,
Hmm.
anxiety. So there's a new medication that um, is FDA approved for weight loss,
Yeah.
but um, it was originally developed for diabetes. So I said, like, this is a great medication we can use. It's actually good for your heart. It's good for your kidneys. It's protected. Like there's not really any side effects other than nausea. And she's like, okay, like, I'm willing to try that. Like, other than that, the next step would be bariatric surgery.
Yeah.
And so I was like, yeah, it's really tough to get it approved. So I was like, let's check you for diabetes. And of course, it's a number. So we checked her, and she was not diabetic, and I was like, all right, well, I'm gonna still try to prescribe it for what the FDA approved it,
Hmm.
weight loss. And so I tried to prescribe it, and they rejected it, and they said, um, Medicaid doesn't approve this for weight loss. We need to do a peer to peer. And I actually I called the doctor, and there's a doctor that works for the marketplace, Medicaid.
Hmm.
And I said, this lady, I have no other options. She's tried the things that we've tried, like I told her to, for 3 months or whatever they say, and it didn't work. And so they said, well, we don't approve anything for this drug for weight loss, only if they're diabetic. And I said, well, the next step would be bariatric surgery. And they actually said, yeah, we're not going to pay for this medication. And I said, okay, well, like, are you okay with paying for bariatric surgery? And they said, yes, we would rather pay. The doctor that I was talking to said, yeah, like, we can't approve this. Like, if she has to go to bariatric surgery, then we'll do that.
Wow.
Yeah. And it's actually something that's like healthy for you. It's there's no side effects, and they would not approve it. And there's been like multiple patients like that for me.
That's crazy. And man, that is just these things are probably all tied together in some ways as well. Like I imagine, her depression is probably is often tied to self-image,
Mm-hmm.
and your sense of your sense of self-worth is tied to your physical appearance in some way.
Mm-hmm.
And an argument could be made that perhaps she might be able to handle her depression better as well if she was able to lose this weight.
Oh yeah, it does. It all ties together. I mean, people that are overweight and don't know how to, like, aren't living health like in a healthy way, of course their mood's gonna be worse, and
Hmm.
so it's a big cycle.
Yeah, it affects their energy levels and like all those other things that
Mm-hmm.
you were describing with this patient.
So we're gonna continue paying for a daily antidepressant. We're just gonna keep pushing, whatever we're pushing, like the medications, to try and patch up the issues and pay for bariatric surgery, but no one wants to like fix the issue that's actually at hand.
Hmm. So you mentioned one thing when you were telling that story that I wanted to continue off of, and that was the fact that this patient had issues trusting
Mm-hmm.
providers. She had had bad experiences in the past.
Mm-hmm.
I think especially um, this pandemic in particular and the environment that it's
Mm-hmm.
created has caused a lot of mistrust in the medical profession at large.
Yeah.
Not necessarily people's individual doctors. I think most people still trust their doctor, but in particular, a lot of these doctors, like high profile doctors that have spoken on cable or network news and have given their opinions that has frankly a lot of them were wrong opinions, or frankly a lot of these cases were outright admitted lies that were told supposedly for good reasons, like when the Surgeon General first came out at
Mm-hmm.
the start of the pandemic and said, if you're people do not need to be wearing like an N95
Yeah.
mask.
Yeah.
They said like a cloth mask will work fine. Well, then they came out a few months later and they said,
Everyone
actually,
needs.
we said that because we didn't want there to be a shortage
Yeah.
within the healthcare
Yeah.
profession, and for care providers and physicians to not be able to get those. We didn't want like a rush happening. So of course, their claimed intention was good. They didn't want healthcare providers to go without much needed and scarce PPE while this global situation is happening. But at the same time, of course, that reduced public trust.
Mm-hmm.
And you have high profile, very political figures that are doctors like
Mm-hmm.
Tony Fauci and other political appointees of sorts that were either wrong or
Or just lying. Yeah.
intentionally dishonest. Yeah. And that has just reduced public trust so much
Yeah. Mm.
within the profession. How has that affected, how have you seen that affect your,
Yeah.
you and your peers?
Honestly, I think most of us go by what the recommendations are. So if the CDC or the the
FDA.
things, no, what's it called? There's there's a governing body that like decides like who needs to get vaccinated for certain things, and like as childhood or even adults, and like most of us go by that, the USPSTF, the United States Preventative Task Force.
Okay. See,
Yeah.
I've never even heard of that, and I'm pretty involved with a lot of this healthcare policy.
Yeah. So as traditional doctors, we have to go by that, and for the most part it works. And so we and especially like schools and like colleges, like they expect that level of like whatever the USPSTF recommends, like
Yeah.
that's what they expect. So we go by that and we say like, okay, like we have to give you that. So when it came to the pandemic, it was different because on one end, like we were hearing all this from the CDC, the USPSTF, um, telling us one thing, and you know, it was true for the most part. They definitely did lie about a lot of things, and and we were kind of like, oh, that's weird. Like a lot of doctors kind of like just fell into line. Like we um
You were just reiterating what you were hearing, even
mhm.
though you knew
Yeah,
that it was probably not true, or
even
that,
though it
yeah,
changed from like week to week,
yeah.
we just fell into line, and because you know we saw the consequences, and again, like doctors are supposed to weigh out the risks and benefits, so we kind of like looked at this and we saw the risks, we saw the negatives, and so when we saw that, we were kind of like, okay, like that has to outweigh whatever whatever else was coming. So we kind of jumped on board with that, and I was guilty with that. I think that as things changed, we had like you're supposed to kind of adapt to how things change.
You mean when new studies were coming out and more
Mm-hmm.
information was available
Yep.
as this progressed?
Yeah. Exactly. And we didn't have everything out there for us. And as it did, most of my colleagues or most doctors would probably still side with the CDC and whatever they said. Um, the smart doctors would probably weigh out like what are the risks and benefits? Like, is it really worth it? And I don't think a lot of people do that.
Yeah, I mean, even still today, regarding vaccination, you have vastly different perspectives from country to country. You
Mm-hmm.
know, even um, if we're talking about like developed countries with advanced medicine practices, like Europe, Canada, and the United States, Australia,
Mm-hmm.
those countries in particular, Canada, still, Canada had pre-purchased at the start of this year enough doses of mRNA vaccine for their entire population to receive 4 boosters per year. I don't think that they've mandated 4 boosters per year,
Mm-hmm.
but they have bought it. Like their population is like 30 something million. They bought enough doses at the start of the year to ensure that they would have enough for 4 doses per person for every man, woman, and child, like in the country.
Mm-hmm.
And that just makes you wonder when you have these countries that have much stricter and rigorous regulation on this, like Australia, like Canada, like Israel,
Mm-hmm.
and then versus the other countries that took a different approach, several of the Scandinavian countries, and there is no uniformity in any of this,
Mm-hmm.
right? Everyone is operating off of their own governing body, their own variation of the
Yeah.
CDC
Yeah.
within their countries, and we've seen how this has caused consequences for us right now with this baby formula shortage
Yeah.
because of our adherence to our own FDA guidelines. Europe actually has higher regulatory standards for a product like baby formula than the
Mm-hmm.
United States
Yeah.
does.
Yeah.
So there's no reason why we should not be comfortable with importing baby formula from Europe,
Yeah. Yeah.
because knowing that they have actually higher standards
And
than,
they're starting to
yeah,
now.
they
Yeah.
they are now,
They're now.
but
Yeah.
but you got to ask yourself, why was this not always the case? Why didn't we just
Mm-hmm.
why did our governing body not do the work
Mm-hmm.
to come to the same understanding?
And again, it comes down to like how much do you want to trust those regulations? Like for most physicians, we were just like we should trust them 100%. Like keep going. Like whatever they say is right. And the same thing goes with the formula. It's like we want like the highest, whatever standards, qualities. And at some point you have to say like, is it worth the risk? And I think that's where I eventually like stepped back and said, is it worth the risk to for the things that we know are side effects of this vaccine? Um, um, is it worth the risks for the benefits? And
Yeah.
um,
When you had to do a great deal of personal research, like to come to any other conclusion than what is being provided to you by these governing bodies,
mhm,
you have to read an immense number of studies to be able to formulate your own opinion on
mhm,
each one of these individual, you know, situations. And it's
mhm,
maybe a little bit easier with something as broad in scope as a pandemic that's ongoing, that's affecting everybody globally.
yeah,
But you wouldn't have the time to do this for every single individual, you know,
no, no, And it changes, and it changes for the individual, and it changes for the time period too, and it's definitely changed for me, like where right now, like, you know, just because the CDC or the FDA has approved the vaccines for, newborns right now, it's
Yeah.
like I I as a physician can weigh out the risks and benefits for myself or for my family,
Hmm.
and I can do that because I can read as many papers as I want, but like there still has to be that, like, you have to be aware of like weighing out those risks and benefits, and
Yeah.
I don't think most people can do that, and most physicians, a lot of my colleagues can't. They just go with whatever the guideline is,
Hmm.
and that's unfortunate.
Yeah. And yeah, regulation and the regulatory environment in which things are produced and intellectual property are like both big factors in this. Glenn and I actually talked about pharmaceuticals a little bit in our
Hmm.
last episode, in terms of why so much of our critical pharmaceuticals are manufactured overseas when pharmaceuticals are not expensive to produce, right? The
Hmm.
intellectual property is what's
No.
valuable, and but actually compounding them is very cheap.
Yeah.
Under normal circumstances, but because of the regulatory environment that the same producer, like let's say just arbitrarily Abbott Laboratories, if they're making a drug in the United States or in Europe, they have to adhere to much higher standards and spend much more on compliance costs
Hmm.
than they do if they were, let's say, they were to open a arm of their company in China, for
Hmm.
example, and they can't own the full company in China. That's the nature of doing business in China. If you set up shop in China, you cannot own the majority of your company. The
Yeah.
majority of your company has to be owned by a Chinese holding company or by something like that.
Hmm.
And I think that's how we got into this situation of so many of our pharmaceuticals being produced in China and India was because the cost of regulatory compliance was much lower there,
Hmm.
even though to get them produced there and then import them to the United States was more cost effective than producing them here
Hmm.
itself. And Puerto Rico used to be a major area where our pharmaceutical producers were producing. I think in part because though it's a U.S. territory, the regulatory environment was a little bit more lax,
Yeah.
or perhaps the strictness of the compliance officers was a little bit more lax. But
It's
um,
actually not that. It doesn't have to be overseas, honestly.
yeah.
Like there's so my brother-in-law works for a functional medicine clinic,
Hmm.
and they they prescribe like the same weight loss pill that I was trying to talk about, or injection that I was trying to talk about, that
Yeah.
was actually, good for heart, good for kidney, and helps with weight loss. So it's, whatever.
Yeah.
And they prescribe to a pharmacy, and there's one in Arizona and there's one in Florida, where they compound it themselves. So they get the raw material
Yeah.
and they add like saline to it. That's it, or B12, and they can call it their own, and they basically can distribute it at like a fourth of the price.
So this is a brand name drug typically.
Yep.
Okay. And that's interesting. I didn't realize that that making a simple modification to
I didn't know that
yeah.
either. And there must be something with like the state that like
Yeah.
depends on that, but like of course, like they're not held at the company that they're cutting out the middleman, basically. Like
Yeah.
they're cutting out the company that distributes it based on their formula, but they have the formula and they can just distribute it. Just it's a fraction of the price.
Yeah, a lot of times though this is protected intellectual property, the information is out there
Hmm.
on it. I literally experienced this myself recently. A medication for a cosmetic like a largely cosmetic issue that I
Hmm.
have. The most effective drug for me was a brand name drug
Hmm.
that was $1,700 for a 30-day supply. Well, my father's a pharmacist, so he had identified that all this company was doing to create this brand name
Was
drug was
mixing.
combining two
Hmm.
generic drugs, and the cost of the two generic drugs and for me to compound this myself here at home is $100 instead
Mm-hmm.
of seventeen hundred
Mm-hmm.
dollars, and that's just absurd.
It is. I mean that. Yeah, they've found a way to like market certain things that they've mixed together.
Yeah. That's just so crazy to me that you can even have a patent on and call something sell something as a brand name
Yeah.
at a certain price point when it's literally two generic drugs that
Mm.
are on the market and
And
widely
there is
distributed.
some degree of when a drug first comes out, there's like a certain amount of time that they can have the patent on it
Yeah,
because they have to pay back like the research that costs. Like
that's what they
I
claim,
understand that.
but a lot of that research was not even paid for by them, right? A lot of it is research that's coming out of universities, and they benefited from this public sector research in order to create a private drug.
Yeah. But there has to be some form of incentive for people to do that research.
Sure. And that is always the argument that's been used. And to an extent, I think the entire world benefits from the state of the U.S. drug market
Mm-hmm.
because the United States spends so much money on researching and developing these drugs because there is such strong financial incentive to do so.
Mm.
The rest of the world eventually gets those drugs. You know, we don't hold the intellectual property rights to those indefinitely.
Mm.
And some countries which don't even honor our intellectual property laws will just even right after that drug is released will immediately, reverse engineer it and
Yeah, yeah.
start making it right away.
Yeah.
So there's not even a lag time necessarily.
Especially when it's something natural like a peptide or which is exactly what this weight loss drug is. It's a peptide. It's something that's so natural that you can reverse engineer it. Like you
Can
can
you describe what a peptide is?
it's like a chain of amino acids
Hmm.
that your body like interprets almost like a hormone. I mean it's basically a hormone. So your body interprets it as, what you feel when you're full or what you feel when you've had too much to eat.
Interesting.
Yeah. So that's basically what this drug is, and it's natural. And so these pharmacies in other states have been able to reproduce it without taking without copywriting it, basically.
Hmm. Yeah, and that's been a major point of contention with this global effort to deploy the vaccines
Mm.
for COVID. It's there's been this demand to produce some of these, protected intellectual property to be able to produce those overseas, and the companies that developed these vaccines said, "Well, no, we don't want to do that. Of course, we want to be able to profit off our
Mm-hmm.
research." And yeah, that's been a major point of contention between individual governing bodies within these countries, like the UK and the US, that developed the very early ones, and the more highly effective ones
Mm-hmm.
than like the Russian or Chinese uh,
Yeah.
versions, and uh, and the World Health Organization. The World
Yeah.
Health Organization, has a strong stance that they want all of this intellectual property to be freed up. And Bill Gates, actually, who's been a major advocate of, vaccination campaigns, not just for this current pandemic, but just broadly speaking, and the Gates Foundation has invested heavily in malaria research and several other
Mm-hmm.
areas. He has actually been on the other side of this issue than you would expect him to be. He has been on the side of protecting this intellectual property and ensuring that these companies can continue to profit off
Mm.
these drugs rather than freeing up these patents and allowing everybody to produce.
Yeah. Interesting. I didn't know that.
Yeah. Well, and it makes you wonder like what would happen if we were in a situation where there was a much more catastrophic pandemic in the future. Like
Mm-hmm.
if we were to experience something that was to the level of, the bubonic plague or
Mm-hmm.
something like that. Like, and even, I don't know, like modern treatment might prevent something like the bubonic plague from even being as severe as it was. I mean, just modern sanitation practices, even,
Yeah.
a lot has changed obviously since that time period, but I do wonder if there was something that was far more severe than the current pandemic that we underwent, like what would happen? Would there actually be a force of change in this intellectual property environment?
Honestly, I think this pandemic has changed that.
Yeah.
Um, I'm not saying that like I'm not here to like vouch for the vaccine, but I think that like this was like the first time that they did spread that. Like they shared it, there was shared information.
Yeah,
Probably the first time between pharmaceuticals, which I
really.
hate.
Yeah, yeah. I do see what you're saying. I definitely think that yeah, there was a lot of an increase in that information
Hmm.
sharing, and
If that was the only thing good that came out of it, like maybe that was it.
yeah, yeah. I wonder. I mean, it's easy to point to all the ways in which that's a good thing, but there's also probably areas where that's uh, causes consequences.
It was once we started to say like it needs to be universally like mandated. Um,
How so?
well, I mean, for example, like again, it changed
Yeah,
the variants or whatever you want to call it. Like it changed. So the flu vaccine, for example, like we give that once a year. It's probably 40% effective, less than 50%, and people still get it year round.
yeah,
Um, so all of a sudden, like we think that we have outsmarted this virus that is changing constantly, like, and you're gonna get it every 3 months. Like, I don't think that is realistic.
yeah,
And again, risks and benefits. Like, if someone is immunocompromised or around someone who's immunocompromised or elderly, like that's a different story. But
hmm,
like, why would we don't give the flu vaccine 3 times a year?
yeah.
And again, and
So you're
right,
saying that like we could do that, and that would have marginal benefits,
yeah,
but we just we our risk assessment says this is not necessary.
yeah. And someone who can look at a patient and say like, oh, like you're someone who probably should get this vaccine. Like, yes, like you should, but and you talk to your healthcare provider for that. But like
Yeah,
again, like even the flu, like we do it once a year. So why would we give someone a vaccine multiple times a year or a booster like every 3 months when it's currently, like as of right now, June
yeah,
2022,
yeah,
like it's just it's as common as the common cold. So like why would and someone who's older, like sure, maybe it's worth the risk, but you have to weigh that out.
yeah. And n- this is something we know by the data that we have. None of these, vaccines, whether for the flu or for COVID, are 100% effective, and
Yeah,
we will
that's
never
what I'm
have
saying.
a
Yeah,
100% effective
the
solution.
viruses are always changing, and that's why I said like
Yeah,
the flu vaccine that we give is, you're predicting it based on I think we predict it based on Australia or somewhere in the UK. We
hmm,
predict the variant that's coming into our country from somewhere else that's already been
interesting.
there. And we try to outsmart these viruses, but you really can't. Like the
Is that
usually
because the flu typically spreads in colder seasons, and Australia
yeah,
experiences their winter at a different time than we do?
yeah,
Mm,
it spreads that way, but it's usually less than 50% effective. But I mean, I still get it like every
yeah.
year, like whatever. Like for me, it's and depending on the person, like
Well,
it's
for
it's
you,
it's
yeah,
worth a
getting the
risk.
flu
Yeah.
would be a pretty big inconvenience for you,
Well,
I
and I'm
imagine. And
exposed, like we're
yeah, you're
exposed to it more
exactly you're
often.
exposed to
So
it. Yeah.
again, like you have to weigh out the risks and benefits,
Hmm.
and getting like a booster for something every 3 months, just as like right
Yeah.
now with the current variant that we're seeing, like it doesn't make sense to me. So
Yeah.
I guess you really have to weigh it out for like w- what it's worth for you,
Hmm.
because yeah,
Yeah.
there's no 100%.
And that is why I think, the advice that should have always been given to most people is talk to your healthcare provider about
Mm-hmm.
this, not don't listen to what you're seeing
Yeah,
on
yeah.
the news. Don't listen to, that article that
Mm-hmm.
was written to scare you and to drive clicks.
Mm-hmm.
Talk to the actual people that are
Who know
responsible
you?
for helping you make these
Yeah,
decisions for yourself.
exactly. And yeah, there's no 100%. Like for viruses, like we can do our best to mitigate the chances of that spreading in our community,
Hmm.
but there's no 100%. Viruses are always going to change.
So yeah, that's one thing and that's another thing we talked about in the last episode was just how there's this duality between um, sort of, and I'm simplifying it by saying this because there's been vastly disparate responses, like we talked about, from Western countries, but China has taken their position, their zero COVID stance, and they have also, mandated their vaccine, the one that they're producing,
Hmm.
which all all studies indicate is far less effective than virtually every other vaccine that's
Oh,
available on
really?
the
I didn't
market.
know about that.
Yeah, it's not a highly effective. I think the Russian vaccine may be less effective than this, but I haven't seen the numbers on India's vaccine, and there's a lot of them on the market now. I
Hmm.
think there's like seven or so at least, right?
In in the U.S.
No, 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 just
Oh,
globally, like major ones.
I don't know about
Yeah,
those.
Mhm. Yeah. I do find it interesting that there there is just this. Even in spite of knowing that you are not going to have a perfect solution, that China has opted to take this strategy, even going so far as to, and I haven't checked recently on the status of this. I think those cities have started to open back up in certain capacities, but we were talking about how Beijing and Shanghai, when we recorded our last episode, were still locked down,
Hmm.
like completely locked down.
Yeah.
And that's crazy to think that, 2 years after the start of this, that we were still seeing places in a situation like that.
Yeah. Yeah. And I mean, I'll say this about like the lockdowns. We were talking about this the other day. Um, it's very interesting. Like there's again risks and benefits to locking down. And when it first happened, like we had no better option. So
Sure.
when we didn't know anything better, like of course I guess we locked down. It's very interesting that the uh the the CDC or whoever like makes the recommendations for like where a child should be at certain ages,
Yeah.
um, they actually changed where a child should be for their language skills. Um,
Oh, yeah.
yeah, this
Yeah.
just happened like last year for a kid who's a year old versus 15-year old or 15 months old should be able to speak a certain amount of words, and like they just changed it like, and they threw it in very subtly, like it wasn't like a big deal, but like again like things that should be open, like we should talk about this, like that's okay if that was a consequence, but like
The
why.
government doesn't want to accept that a
Hmm.
policy that they imposed caused a consequence
Yeah,
like that.
yeah. And if that was what we had to do at that time, that's fine. But why is it not something that like we're accepting as like a medical community? Well,
Well,
really a lot.
looks like our cameras have died, but we'll close this up on just audio here. But I want to thank you for coming and talking with us about these subjects. I think would be great to have you on again in the future when Glenn is also with us. I'm
Hmm.
sure he's probably got some questions he'd like to throw your way
Oh,
as
I would love
well.
to hear it.
Yeah, and yeah, this was great. This is your first time doing anything like this, right?
Hmm.
Yeah. Well, I'm glad you were able to be here, and we are Esoteric Artifacts. This is available on YouTube, Spotify, Google Podcasts. Apple is for some reason not distributing us, but I'm got to figure that out. Um, thank you for listening, and we will be back with Glenn in the next episode because he's going to have his studio set up, and though we're not going to be in the same room, we're hoping we can still have the same sorts of conversation. And yeah, so please like and subscribe below and on whatever platform that you're listening on. And thank you.